Emergency departments across Australia are seeing a 200% increase in presentations linked to pregabalin withdrawal, yet most doctors still don't recognise these symptoms. A 45-year-old teacher presents with severe anxiety, insomnia and flu-like symptoms 3 days after her GP suggested she just stop her Lyrica. Her withdrawal symptoms were so severe she thought she was having a heart attack. I'm Dr. Ferghal Armstrong, and today we're examining why pregabalin withdrawal has become one of Australia's most underdiagnosed clinical challenges. You'll learn to recognise withdrawal syndrome, understand the complete symptom profile, and discover safe tapering protocols for this Schedule 8 medication that demands more respect than doctors realise. Since pregabalin became Schedule 8 in 2019, prescribing patterns have shifted, but withdrawal recognition hasn't kept pace. The National Coronial Information System now documents cases where pregabalin withdrawal contributed to adverse outcomes, something virtually unheard of a decade ago. Here's what's particularly concerning. Withdrawal can occur after just 2 to 3 weeks of regular therapeutic dosing. We're not talking about high-dose misuse scenarios. Patients prescribed 150 milligrams twice daily for fibromyalgia can develop clinically significant withdrawal syndromes. The TGA rescheduling decision wasn't just about abuse potential. It reflected emerging evidence that pregabalin creates physical dependence more readily than initially recognized during clinical trials. But here's what makes this so dangerous for patients. Pregabalin withdrawal presents with a distinct constellation of symptoms that follow a predictable timeline. Understanding this pattern is crucial for recognition and management. Early symptoms emerge within 12 to 48 hours of dose reduction and include anxiety and agitation, often severe, disproportionate to the patient's baseline, insomnia, difficulty falling asleep and frequent wakening, nausea and vomiting, sometimes accompanied by diarrhea, headache, typically described as pressure-like or band-like, fatigue and weakness, profound exhaustion despite sleep attempts. Intermediate symptoms develop between days 2 and 4 and represent the peak withdrawal period. Tremor, fine tremor of hands, sometimes generalized. Sweating, excessive perspiration, particularly at night. Palpitations, rapid heart rate, sometimes with chest tightness. Hypertension, blood pressure elevations, particularly systolic. Confusion and cognitive impairment, difficulty concentrating, memory problems, flu-like symptoms, muscle aches, joint pains, general malaise. Severe complications are rare, but potentially life-threatening. Seizures, particularly in patients with seizure history or high-dose withdrawal. Delirium, altered mental state with disorientation. Severe hypertension requiring immediate medical intervention. Here's the key differentiator from the original condition. Withdrawal symptoms have a characteristic temporal pattern. They peak between days 2 and 4 and gradually resolve over 2 to 3 weeks, unlike chronic conditions which persist without clear temporal boundaries. Australian emergency physicians are seeing these presentations monthly in major centres, often misdiagnosed as panic attacks, viral illnesses or cardiac events. Pregabalin binds to voltage-gated calcium channels in the central nervous system, reducing neurotransmitter release. With chronic use, the brain compensates by upregulating these pathways. During withdrawal, this compensation creates neural hyperexcitability. The anxiety, tremor, and seizure risk all reflect excessive nervous system activity as the brain readjusts to functioning without pregabalin's inhibitory effects. This neuroadaptation explains why withdrawal severity doesn't always correlate with dose or duration. Individual genetic factors affecting calcium channel expression influence withdrawal intensity. Abrupt cessation is never appropriate for pregabalin, even if the patient requests it due to side effects. The standard approach involves 25 to 50 milligram reductions every 3 to 7 days, but this requires individualization based on starting dose and patient factors. For patients on 300 milligrams daily or higher, consider initial reductions of 50 milligrams every week, slowing to 25 milligram decrements as you approach lower doses. The final 75 milligrams often requires the slowest taper, sometimes 12.5 milligram reductions every 5 to 7 days. Patient response varies significantly. Some tolerate 50 milligram weekly reductions throughout, others need 25 milligram reductions fortnightly. The key is monitoring withdrawal symptoms and adjusting accordingly, not following rigid protocols. Elderly patients frequently require slower tapers and develop more severe withdrawal symptoms. Their reduced renal function affects pregabalin clearance, potentially prolonging withdrawal duration. Patients with anxiety disorders present particular challenges because withdrawal anxiety overlaps with their underlying condition. Consider temporary anxiolytic support during taper, but avoid substituting one dependence for another. Chronic pain patients face the dual challenge of withdrawal symptoms plus return of original pain. This isn't treatment failure, it's expected physiology. Distinguish between withdrawal-related discomfort and underlying pain exacerbations. Pregabalin withdrawal creates downstream healthcare costs through emergency presentations, unscheduled GP visits, and prescribing cascades when symptoms are misdiagnosed as new conditions. The average withdrawal-related ED presentation costs approximately $800 and could be prevented with appropriate outpatient taper management. Multiply this across Australia's increasing pregabalin prescribing rates, and the systemic impact becomes significant. Documentation is crucial. Clear notes about taper schedules, withdrawal symptoms, and patient education help prevent confusion when patients present to different providers during withdrawal. Every pregabalin prescription should include withdrawal risk discussion. Patients need to understand that stopping requires medical supervision, even if they've been taking it short-term for neuropathic pain. Establish regular review appointments during tapering. Weekly contact during the initial dose reduction phase allows symptom monitoring and schedule adjustments. Phone consultations work well for stable patients. Provide written taper schedules with clear instructions about what to do if withdrawal symptoms worsen. Include after-hours contact information and criteria for seeking emergency care, specifically mentioning seizure risk and severe hypertension as red flags. Pregabalin withdrawal recognition protects both patient safety and healthcare system resources. If you're prescribing gabapentinoids, understanding withdrawal management isn't optional, it's essential clinical competence. What's your experience with pregabalin withdrawal in practice? Comment below with the most challenging case you've managed or questions about specific tapering scenarios. Your insights help other healthcare professionals navigate these complex situations. I'm Dr. Ferghal Armstrong, and this has been Cracking Addiction.